So friends, welcome all to this GCCI webinar, Geneticist Clinicians Consortium of India, which is a spin-off that is carved out from Bioclues and RB Bioservices that was founded by me and Kausanayas. So we have about 11 prolific scientists and clinicians as a part of this GCCI, and we have been working strenuously to bridge the gap between geneticists and clinicians. And today we have Deepti Chaudhary, who has kindly consented to be the speaker. But before which, may I request Jenny to introduce the speaker, please. And with the consent from Deepti, this talk is being recorded. Thank you so much. Over to you, Jenny.
Yeah, thank you, sir. Good evening, everyone. It is my absolute pleasure to welcome you all to today's special session of episode 27. Today, we are honored to have with us an inspiring speaker and a distinguished expert in the field of genetic counseling, Ms. Deepti Chaudhary. Ms. Deepti is an HSSC and BGCI certified senior genetic counselor, currently practicing at Lifecell International Private Limited, where she has been making impactful contributions since 2020. She holds the responsibility of managing genetic clinics across multiple regions, reflecting her strong leadership and clinical expertise. Her academic journey is equally commendable. She holds a master's degree in human molecular genetics from the Central University of Punjab, a postgraduate diploma in counseling and family therapy, and a certificate in genetic counseling from PGIMER Chandigarh. She is also an associate member of the GC ASGC Dubai. Her undergraduate studies were completed at the University of Rajasthan, Jaipur. Beyond her clinical work, Ms. Deepti is an active medical writer, passionate about knowledge sharing. She frequently delivers lectures, webinars, and CME sessions focused on genetics, reaching students, clinicians, and patient families alike. Her research interests span a wide spectrum, including infertility, recurrent spontaneous abortions, neuromuscular disorders, inborn errors of metabolism, dysmorphism, autism, and oncology, showcasing her dedication to advancing the field of personalized medicine. With 5 publications and book chapters to her name, she brings a unique blend of academic insight and real-world experience to every interaction. So let's extend a warm welcome to Ms. Deepti Chaudhary as she shares her valuable insights with us today. Over to you, Ms. Deepti.
Thank you so much, Jenny, for this introduction. And at the outset, I would like to thank Dr. Prashant, Dr. Niaz, Dr. Saima, and the whole team for having me here to present my opinions about infertility and genetic counseling, how they walk parallel in the clinical scenarios these days. So without doing a further ado, I would like to present my screen. And Dr. Prashant, you may start with the screen, recordings.
Yeah, yes, please. I've been recording. Yeah, thank you so much.
Yeah. So I hope my screen is visible to you all.
Yes, please.
Yeah. So basically, as a genetic counselor, it's been like 5 years I'm practicing as a genetic counselor. I have seen a lot of patients coming up with not just queries, but with a burden on their mind, where we have to deal very empathically to tell them what they are going to. Because being an adult, coming with a query of infertility is little difficult to be addressed. So basically, we'll be talking about 2 aspects here: genetics, genetic counseling, and in its role in infertility. So basically, genetics is the branch of biological sciences which deals with the transmission of characteristics from parents to offspring. We know that very well, that we all are having our beautiful DNA, where we harbor a lot of changes from our parents, and so on, we pass it so on. So that's the hereditary passing of the genetic traits from parents to offspring. But how does it significantly plays a role in infertility? We'll be talking in the upcoming slides. So we know that as a human, we have our cells, we have our nucleus, and we have the chromosome inside that nucleus, which contains our DNA and our genes in it. If we more emphasize on the DNA, we see there are genes which are beautifully, mentioned as a beads of, a beautiful pearl beads. They are inside our body, making functions, doing a lot of things for a human body. So we see that there is a fertilization that occurs with the haploid cells, sperm cells, and the egg cells, which leads to a diploid cell formation. That is the 46 number of chromosome from where the story begins. So infertility, basically. So the inability of sexually active couples for not using any contraception to conceive for at least 1 year, who are aged more or less than 35 years or 6 months, are not able to conceive, right? So what we talk about infertility is like, it's just one word, infertility. But we have classified infertility into two things. One is a primary infertility and the another one is a secondary infertility, if we talk about. So what does a primary infertility means? A couple that has never conceived, even after having contracept, even after having trial for pregnancy without any contraceptions for 1 year, they never conceive. There is no sense of a pregnancy loss or something that has happened. On the other hand, secondary infertility, have secondary infertility even after having one previous pregnancy which turns out to be normal, or either pregnancy they are able to achieve the pregnancy but that the pregnancy could not go ahead further. So unfortunately, difficulty with the conception affects not somewhere around 15% of the couples, with approximately 20% of these cases are being caused by the male factors alone, and with another 30 to 40% of the infertility due to both male and female factors, including the other factors per se, environmental factors, hormonal imbalances, lot of the things comes in. It's not just the genetic factor we'll be talking about. With contribution of both male and female partners to infertility, it behooves infertility experts to perform analysis of both partners to determine factors that could be inhibiting fecundity. So basically, when we talk about the role of genetics in infertility, we will be talking about the role of genetic counselors, genetic experts, reproductive experts, endocrinologists playing their role, walking hand in hand to achieve a certain answer to that particular couple's query. So as we observe that couples having a regular unprotected intercourse, out of which 50 to 60% will conceive almost within 3 months, 70% will conceive in 6 months, some 85% in 1 year, or some 90% in 2 years. So certain patients can get apprehend and come up to you even after 2 to 3 months of trying for the conception that we are not able to achieve. Some may reach out on the different time intervals to you. So basically, the goal of evaluation will revolve around that we need to identify what is the exact cause of infertility for the couple if they are not able to achieve the pregnancy, to prescribe the adequate therapy, to have a further follow-up of the patient to the concerned faculty or to the concerned doctor to go ahead with whatever the treatment is actually prescribed, provide accurate information to the couple, correct the misinformation gained from family, friends, and Google, because these are the three mediums we often see that there are certain patients that could walk into you with a lot of myths in their mind. They must have heard a lot of things from their families, from their friends, and one good information provider, Google. They read half of the information, half of the way they come to you with lot of the misunderstanding or the misinformations. Providing emotional support during the evaluation and the treatment, because as an adult, a person who is reaching out to us with a lot of information, we need to handle them very delicately and pass on the information in a very smooth manner so that they should not get emotionally and mentally hurt on that end. So not just doing a counseling, not just providing them with the answers of their question, we need to look forward for the psychological aspects also. So the elements of infertility evaluation talks about the medical history for the both male-female partners, which serves as a primary reference to understanding that where we are looking forward to. Focused physical examinations for both the husband and wife, semen analysis for the male, detection of ovulation for the female, ovarian reserves, patency of the follicular tubes, uterine evaluations, and going ahead with a genetic evaluation when we are confident that all of the evaluations done before says everything is going fine and it is not causing any abnormalities. So when we are doing the genetic evaluation, the story of counseling comes in. We have to have a preconceptual counseling, where what test we will do, why it is done, what it will answer, Then going ahead with PGS or PGD, that is something which we involve within IVF procedure these days, and which is turning out to be which is setting a benchmark as a good benchmark for the couples who are looking forward to conceive. So when we are talking about the genetic evaluation, the genetic basis of male and female infertility, we need to understand what will be the cause, what needs to be addressed. So infertility affects approximately 50 million couples worldwide as per WHO, and prevalence is rising every day. So 25 to 30% of the couples with idiopathic infertility are likely to have genetic etiologies for their conditions. So if we talk about the genetic etiologies, what it would be, it will be either a cytogenetic abnormality on the chromosomes, or genetic defects, or some monogenic disorders that leads to infertility, and having epigenetic alterations like methylation, acetylations that would come up as a medium for infertility to the patients. Why we need to find out the genetic causes of infertility? Basically, to establish the cause and the diagnosis, to personalize the therapies for the patient, and to understand the recurrence in the next generation, whether they will be able to conceive via natural conception. Is there something which will hamper their next, the upcoming pregnancy if they conceive with certain treatments, or some evaluation needs to be done? So there is a bunch of questions that would come up with recurrence in the next generation. So the presentation of chromosomal abnormalities talk about, like, starting from the chromosomal anomalies, we have balanced chromosomal rearrangements where we see that the chromosome number remains the same, but there is certain information which has been transferred over the time period, which is leading to, which is not exactly leading to some physical or some kind of structural abnormality to the patient so far, but has hampered the internal structures. Like if I talk about on the chromosome, there is certain abnormality leading to infertility, which will eventually be coming up as as a diagnosis when we only investigate a adult. There are certain chromosomal imbalances which we can easily diagnose if we talk about, like, commonly the trisomies, the partial trisomies, monosomies, the deletions, the duplications that would come up to. So if we talk about a deletion, it is removal of a chromosome segment. Basically, a duplication is a repeat segment. There is an information double. Inversion is the segment with the reversal of the information within a segment of the chromosome. A translocation means, basically, information has shifted from one chromosome to another chromosome. So the spectrum of genetic testing goes around from pre-conceptional, like the pre-conceptional counseling for male, female, testing of male and female to understand what they are going to actually, pre-implantation when we are looking forward to give them the answer with either an IVF procedure, and whether it will be just their eggs and sperm utilized, or is it something we have to involve either a male or a female donor. And then the story of prenatal comes, where we'll be talking about the fetus evaluation. What is the requirement of doing a fetus evaluation, if at all we are going to have the evaluation of the fetus or not. So these are the spectrum of genetic testing that goes around male and female. So what are the causes of infertility? If we talk about, there are multiple factors, as I said. It's not just the genetic factor overall. It's the endocrine dysfunction, the ovarian disorders, the fallopian tube and the uterus disorders, sperm dysfunction, testicular disorders, and the genetic abnormalities. So it's the grossly images which depicts a lot of innate stories, where I cannot go precisely very deep into one-on-one. We have to understand that there are multiple factors ranging from hormonal, shape and size, motility, everything needs to be taken care. So when we talk about infertility by gender, the female factors have 30 to 40% involvement. The male factors again have 30 to 40% involvements. But when we talk about unknown factors for both male and female, it is a gross of again 30 to 40. So we are still having certain gray zones that needs to be addressed even after doing every set of evaluation, every test that needs to address for the couple. Still we can have certain gray zones where we cannot address, or we don't have the technologies known so far, and we are still working on to get the answer for this infertility. So workup. So what exactly needs to be done? We have to have a very clear history from the parents. That is the key to the addressal of the queries. Focused physical examinations and labs and specialized tests needs to be done. So when we talk of, I'll be going one on one about male and female infertility, what all tests can be done, what all disorders are there which needs to be kept in mind when we are talking to a person or a couple when they come up with a history of not conceiving, and either they come up with a history of conceived once, have one baby, one missed abortion, then having a baby, or IUDs, that all needs to be addressed. So if we talk about history, male infertility precisely, we need to understand some sexual dysfunction is there, some STD is there, trauma, past medical history, surgical history, overconsumption of obstructive things, cigarettes and alcohols, common medications which a patient can go ahead with, heavy smoking, impotency, decreased blood flow to the penis, abnormal semenogram. Obviously, we directly go whenever a patient comes, walks into our OPDs, we see that they're not able to conceive. The primary test we go ahead is doing a semen analysis or to understand the sperm count of the patient. So we can go ahead with the sperm count analysis, motility testing, and understand the abnormal forms. So basic evaluation, as I said, semen analysis and the tubal analysis. So what does the semen analysis will talk about? The macroscopic parameters about the volume, appearance, color, liquefaction, viscosity, and the pH. Every small information gathered serves as a good medium to address what we are exactly going to answer to the patient. The microscopic evaluation, the concentration, motility, morphology, concentration, agglutination, everything will serve as a proper medium. So the causes of male infertility, if we talk about, there is abnormality in the sperm production. The adequate sperm production is not there. Sperm functioning is not there. Even after having adequate sperm productions, there is abnormality of the function. The obstruction in the ductal system can cause, there are certain causes of male infertility. So there is one common term which we have understood about like male infertility is zoospermia. So oligozoospermia, azoospermia, these are the two common abnormalities which we frequently observe a male coming with certain infertility or a male coming with a query of. So abnormalities, if we talk about, oligozoospermia counts for like 2 to 9% of the males, and zoospermia talks about like 2 to 7% of the males. But we cannot skip the another zoo like teratozoospermia, thanospermia. There are multiple zoospermias which needs to be understood and which needs to be addressed on the basis and the type. It's not that one zoospermia the patient has come with, we can go ahead with the same kind of like investigation for all the patients. So the genetic related male infertility, if we talk about, so abnormal genotype in the somatic cells, we commonly see that there is a Klinefelter syndrome, Noonan syndrome, where majorly the patient have chromosomal abnormalities, but these are being captured very early because these days parents, even the doctors in the primary centers are very, active. They easily understand that the baby is having certain abnormality and they easily capture these kind of like information. But previously, if we talk about in the past, there is a high possibility that these patients would have been skipped before they go ahead with the pregnancy plannings. Certain monogenic disorders like cystic fibrosis, CFTR gene, cat sperm gene, and this Calvin gene, immotile ciliary syndrome, Cartinger syndrome, and globozoospermia. These are certain polygenic or monogenic conditions that eventually contributes to infertility. And as I said, there are certain information which gets deleted over the chromosome itself. So there are certain deletions or duplications playing the role in the background. One is YQ microdeletions. So if we talk about what if the chromosomes are absolutely fine, if the genetic factors are completely fine, still there are certain abnormalities that could be coming up, like epigenetic abnormalities. The sperm mitochondrial defects can be there. So we need to address everything very beautifully. We can't load a patient with multiple testings on one go. We need to have one-on-one testings. I'll be discussing that further also. We need to have series of investigation one-on-one at least to address them patiently. So the genetic testing in male infertility, if we talk about, we usually get a karyotyping done, which is a primary test to understand whether the male is having any kind of like chromosomal changes. Then, if we find out certain changes on chromosome Y, we can proceed with doing a Y chromosome microdeletions. We then, if both of these tests are completely normal along the side the hormonal evaluation for the male and obviously the structural investigation, then we can look forward for the CABVDs. There will be certain hints when we are doing the investigation that the patient can have absence of vas difference also. We can suspect a cystic fibrosis abnormality. We can look forward if the patient has hypogonadotrophic hypogonadism, then CAL1 gene can be suspected. To this, we can do a single gene analysis also if we have a confined understanding that yes, this is what we are thinking and the patient 100% fits into. Otherwise, we can look forward doing a panel of testing. Like a panel of testing means basically involving not just the chromosomal factors, but it will involve the genetic factors also. Certain gene panels will be there, or doing a clinical or an whole exome can be helpful at times. So 5.8% of the infertile male have chromosomal abnormalities. So majority of our questions can be addressed when we are doing the chromosomal evaluations, but not just we can say that every patient has the similar morphology. They may have variations that could lead to certain novel findings also to us. So if we talk about the causes of male infertility, as I said, there will be a huge list of. We can see the sex chromosomal abnormalities are there, Klinefelters, XYY, 45X males are there. There can be, isochromosomes also, translocation, inversion, satellite marker chromosomes are also there. Polymorphisms can also have impact on infertility, but yes, it is not exactly been reported. But to certain patients, we have seen that having QH plus, QH minus heteromorphism, still the patient can have infertility and can requires an further investigation. So inversion of chromosome 9, which is common for both male and female, gene mutations like, as I said, the microdeletions and duplications, Coleman syndrome, androgen insensitivity, which can be complete or a partial. Complex genetic disorders like certain dystrophies, alpha reductase deficiencies can have, can lead to male infertilities. And obviously, there are certain rare cases of male infertility or syndromes where the minor manifestations can be there if it is not diagnosed early, like Noonan, Prader-Willi, cerebral ataxias, anemias, Fanconi anemia, and obviously the beta thalassemia patients can also have infertility. So going ahead with the female infertility. So factors affecting the female infertility is not very, dissimilar than the male. Again, we have to understand the structural and the physical morpho, that we have to understand the ovulation disorders, the tubal damage, the fallopian tubes needs to be evaluated properly. This age of conception largely is a point of concern for the females. If they are more than 35 years of age, there is a high possibility that there will be certain delays we can expect in achieving the pregnancies, or some hormonal inductions needs to be given. Obviously, it reduces the chances of spontaneous conception to large. Low coital frequencies and inappropriate time of intercourse to the ovulation, no previous pregnancy. Smoking and obstructive intake, again, for the females is equally affecting, which affects the male also. Malnutrition, obesity. We see a lot of females coming with PCOS these days, with having a lot of hormonal imbalances, obesity, or a set of misdiagnoses that would come up, and we start them giving them some kind of modifications and alterations, and then we can see eventually the results go better when we see when they are looking forward to conceive further. And underweight, obviously, it's not just obesity. If the female is underweight, then definitely it will also lead to certain factors of infertility. And endometriosis, fibroids, and inflammatory diseases, a woman has a bunch of other things, that there's certain infections like lupus anticoagulant, LAs, there are multiple other things that needs to be evaluated on the female part, like certain cytomegaloviruses, rubella. These all can also lead to female infertility frequently. So if we talk about the dysfunctions that could come up to, from pre-ovulatory follicular phase till the fertilization phase, till maternal effects, implantation in uterine, post-implantation, postpartum, everything we see, there is a bunch of genes we can see on our screen that plays a role in the background, right? And we cannot skip if we have such patient coming up to us with either one test done and they say ki, theek hai, ek test hai, which is fine, hormones are fine, but we cannot skip doing such extended evaluation to just get the answer where the key is on the role. So we need to understand there are multiple genes playing a role in the background from pre-ovulatory till fertilization. I'll not be going very deep for one-on-one genes. We can just see there are certain which are highlighted, have a potential and a defined diagnosis or literature published so far for those. So if we talk about the female infertility and how can we diagnose, as we see, we start with doing a basic karyotyping, then we can go ahead doing a cystic fibrosis panel for the female also, then hormonal investigation for the infections also, like inflammatory, autoinflammatory things also can be checked on. So if we talk about Turner syndrome or gonadal dysgenesis with short stature is commonly which can be observed easily these days. We have a high patient load for Turner's these days, and obviously there is a mosaic patterns also that also needs to be addressed for both male and female. There we have in mosaic, if we talk about, we have two types of cell where we have to decide on the type of percentages which we are getting and the manifestation of the symptoms of the patient obviously, and mixed dysgenesis. If we talk about translocation, Robertsonian and reciprocal translocation, Fragile X is one condition which we say that it affects a male if we talk about intellectual disability, facial dysmorphism, but a female who is a carrier or who has a Fragile X syndrome can have too large, have a female infertility. Coleman again is one disorder which contributes to female infertility, complete androgen insensitivity. Apart from those, there are certain genes for FSH, follicular stimulating hormones, luteinizing hormones, and these there are certain receptor work, GnRH receptors also, which needs to be understood that these can also play a role for the female infertility in the background. And if we talk about certain rare genetic disorders, like which we usually observe in the infants or kids these days, like mucopolysaccharidosis, galactosemias, Prader-Willi again, aromatase defects, DAX1 gene, beta thalassemias. These are certain things where the patients are coming frequently up to when they have a baby, and they come up to us like the baby has certain abnormalities, and we diagnose them genetically. So these patients can also later have infertility associated. I'll be skipping this. This is which I have already discussed in the previous slide. So fertility evaluation is not just genetic. It's 50-50 from, or it's a contribution of 30, 40, 20, 10 from every, fraternities or every bunch of doctors or specialists who contributes to. Basically, if we talk about the fertility, 50% genetics is diagnosed by a genetic counselor, then a reproductive endocrinologist can talk about the rest of the 50%, that what needs to be done further. So basically, if we talk about genetic counseling in infertility, so if we talk about genetic counseling, I would let you go through what genetic counseling is basically. So genetic counseling refers to a guidance of relating to genetic disorder that a specialized healthcare professional, either a genetic counselor or we say geneticist these days, provides to an individual or a family. So before going ahead, I will go with a quick recap that I have shown an image where the human has a nucleus and then our DNA. So if we imagine our genome as a book, there are certain chapters which we can say these are the chromosomes inside our body. And if we talk about the genes, then every sentence on that each page is our gene. So it's a simplified way where we try to counsel with this type of pictorial images to the patient, that how this technical or how this new age of science can lead to certain abnormalities to the patient, because not all people come with furnished informations. They may come up with certain, half of the way informations, and they either can misinterpret or misunderstand you a lot of times. Because if we talk about high-end genetic testing, for to them infertility may sound a little smaller sometimes, but it's a bigger question that needs to be addressed. So, who are genetic counselors? We are specialized people who provide information about how genetic condition could affect an individual or family. We try to interpret the genetic test done, designed to help the estimate risk of the disease, like what is the risk of reoccurrence? Is it something they need to be panic about, or they need to understand, like, it will it cause any kind of like abnormality to them? Convey the information to address the concerns of the family or individual, and help them to make an informed decision about their medical situation. We are somebody who sits, who discuss for somewhere around like 40-45 minutes to sometimes 1 hour with the patient, but we are somebody who cannot take the decision on the patient's behalf. So we have to be highly non-directive when we are performing the genetic counseling, and we can put forward certain situations to the patient where they can choose whatever they want to go ahead with, because eventually we are the information providers. We are not somebody to take the decisions on the patient's behalf. So provide psychological counseling is also to help them to adapt to the condition or the risk. Obviously, as I said in the starting of this presentation, that whatever we are doing as a counselor, as a somebody who is treating the patient, or somebody who is helping the patient, we have to have this understanding in mind, that we have to be psychologically keeping the patient boosted. We cannot keep them drained. We cannot push them eventually to some kind of like traumas. We have to eventually take them out from that psychological trauma. So these are certain skills which needs to be kept in mind as a genetic counselor, that we have to have scientific and analytical skill, where we can clearly understand what is documented on the report, how does this report information goes about, what needs to be conveyed to the patient, is it something which is highly necessary for the patient to be known. So we have to understand everything. Along the side, the cultural sensitivity needs to be kept in mind. Even it's not just the infertility I'm talking about, it's like for whatever the scenarios we are counseling. So we GCs should, genetic counselors should have this professional skills with us. And obviously, when we are doing genetic counseling, we identify the infertility causes, like what is the cause related to infertility, why needs to be answered at multiple places. When we are identifying somebody with infertility, we have to address why, what is the cause of genetic infertility. Is it something which is transmissible? When? The preconceptional age, what? Blood samples for both the partners. So these when, what, and why needs to be addressed at every step when we are performing anything. Like if we are taking the information, if we are doing the genetic testing, then identification of transmissibility to the offspring, like is there something which will bother their upcoming family? Is it something we need to address? When? What is the age of implantations? What is the age of biopsy of the sample? And like what needs to be addressed? What is the sample medium that needs to be taken? Optimization of assisted reproductive technology is something which we have to understand, that just saying pre-implantation genetic testing for any of the conditions will not just suffice the thing. We need to understand that if there is some chromosomal abnormality, then what test needs to be ordered. If the couple has some structural rearrangements, then we have to have PGT-SR. Then if the patient has normal karyotyping, normal evaluation, then too they are not able to conceive. We can give it a try with their egg and sperm, if everything looks normal, and go ahead with doing a PGT-A. Then if there is a monogenic condition which we identify while doing a genetic advanced genetic testing or exome sequencing or panel testing for the patient, then obviously we need to talk about PGT-M. pre-PGT workups. These we have to understand as a individual, conveying the information that pouring off all the information will not just suffice the patient. We have to filter out certain information to them related to their conditions, what they are coming up to. So unexplained infertility, it's not that just we have answer for whatever the questions being raised to us. Still, there is certain things which are underway. We need to understand that there are a lot of things which we have to identify. So 15 to 25% of the infertile couples will have completely normal workups. We will not be able to capture certain things. They can come up with all tests normal, and still we cannot provide them the answer. So we need not to keep on looking forward for doing multiple tests to the patient. Then the best idea is to talk to their referring physician to see if the patient can go ahead with some alternative methods, either IVF or either some donor can be involved with the consent of the patient to achieve the pregnancy. So the emotional impact, as I said, infertility at times or always is very draining for the patient. It has a great emotional burden on the infertile couples. The quest for having a child becomes the driving force for the couple's relationship. Is not just because the couple wants it always. It's more of the societal pressure that what people will say, that we are not able to conceive a baby. The mental anguish that arises from infertility is nearly as incapacitating as the pain of other diseases. Obviously, as I was talking about in the middle of the slides also, that as an adult having everything normal, suddenly coming up with a question on your fertility is a very big pain for the person. It's important to address the emotional needs of these patients. It's always not necessary that if a patient is visiting you, you pour out all the information in one go. You tell them every story in one go. You can just understand their mental status, to how much information they can absorb. Then you can keep a filter in it. You can just furnish that much of information, let them absorb and understand the process. Then you can go ahead with slowly telling the whole story or the background of the case. If they are not if you see they are not absorptive enough, they are not able to understand what you are talking about, you can take a break, you can reschedule your sessions with the patient, and then slowly address what you are exactly trying to convey. So the treatment of options, if we talk about, the advice is to understand, like, there are certain assessments like ovulation inductions, intrauterine inseminations, IVF, ICSI, surgical sperm collections, and obviously donors. So when we capture the type of infertility the patient is having, is it something primary, secondary? Obviously, doing the evaluations to understand what will work as a best medium for the patient. We can look forward for these treatment options, whether OI can be helpful, or doing a donor or doing a XC is helpful for the patient or not. So if we talk about IVF, it is slowly but very rapidly turned out as a medium to expecting patients, that they can achieve the pregnancy very smoothly these days, and the team, the IVF experts are doing a commendable job. They are providing a good happy families to the society. So obviously IVF is something where we talk about stimulation hormone therapies, egg pickups, sperm preparation, egg fertilization, embryo development, then sending those biopsy samples to some labs for the evaluation, or to the hospital for the evaluation, to understand if we at all require some kind of break while doing the embryo transfer, or is it something the embryo which has been prepared is good enough to be transferred. So this was the clinical or the theoretical aspect of the thing. I'll be going for a few cases, then we will be closing the session. So into the clinical case, we have our first case where the 26-year-old male presented with primary infertility and azoospermia diagnosed. We did a panel of testing for that patient, where we performed certain tests like doing a YCMD or karyotyping, CABVD evaluation was done, and other male infertility factors were also evaluated. And we found out eventually the male has a compound heterozygous variant for CABVD. That's in the cystic fibrosis gene, and the intron 9, it was compound heterozygous, where one was a pathogenic and another was a uncertain significance variant. We see that VOUS is still again a gray zone for the diagnosis, but upon understanding and finding out like proper genotype phenotype correlation, we can consider that this could be the causative for the patient. Laterwards, the discussion was done with their IVF specialist, and it was mutually taken as a decision to skip the patient and take some sperm donor within the family for further pregnancy achieving. There is another case where the non-consanguineously married couple, 33-year-old male and female, both were 33-year-old. The male, Mr. X, has CABVD. So we did a couple investigation. We found out, as I said, if you remember, that CFTR is not just for the males CABVD. We can just see that the certain females with CFTR can also have infertility. So we see that CFTR, there was a compound heterozygous variation again identified for the male. If we see there are two variations for the male here in the exon 1 and intron 17. And unfortunately, whatever the scenario is, the female also has exon 4, a mutation on an exon 4, and she was a heterozygous carrier for it. So they wanted to achieve the pregnancy via their self-gametes only. So for this case, we suggested the couple to go ahead with PGT-M to understand whether these the combination of these mutations or any of the mutation is will gonna cause abnormality to the baby or not laterwards. And if they are not able to achieve via self-gamete, then obviously either of them can go ahead with either a female or a male donor can be taken accordingly. So we have to be culturally sensitive also while communicating these kind of reports to the patient. So that was always kept in mind while we were doing the counseling for the patient. So 40 years of male presented with the karyotyping suggestive of 46XY QH+. There is a heteromorphism on the Y. His wife, 37-year-old female, her karyotype was normal. The couple has primary infertility. They never conceived. So we did a panel testing again for the male and female both. So the male, there was nothing which has been identified. To female, if we see, there is one variant detected for the female which is associated to thrombophilia related recurrent pregnancy losses, and it was PROS-S1 gene which we have identified. There was a mutation on exon 13 and only one copy was affected, saying it as an autosomal dominant. Again, a VOUS coming as a gray zone to us. So we asked for the thorough investigations, and we suggested that, as we know that heterozygous mutation on PROS1 gene can also lead to infertility at times. So obviously anticoagulants, or as a management, if we talk about, we can give anticoagulants or certain DOACs to the patient so that they can at least see whether they can viably get the pregnancy and they can achieve it or not. And laterwards, though we have lost the follow-up for this patient, but yes, we can say that it's not always finding the homozygous or compound heterozygous mutations can lead to. We need to understand the inheritance patterns also, and again the patient's manifestations, what symptoms exactly the patient has come up with. So for this, it was recommended to go back to the gynec's and fertility specialist and to see if some anticoagulants or some blood thinners can work for the patient. So Mrs. X and Mr. Y are non-consanguineously married. Couple has conceived twice and has miscarriages at 2 to 3 months of gestation age. Both the fetuses did not have cardiac activity, and it showed poor growth on an ultrasound scan. Mrs. X has a history of thyroid prior to her first pregnancy, and no pre-pregnancy workup was done for the couple. So, pre-pregnancy usually is something like, we visit, when we start planning the pregnancy, we visit a gynec. We usually now started talking about, like, is there any kind of like supplementation we need to take? Is there any kind of like, medication that needs to be taken? Something that needs to be avoided also, like, certain, skin treatment that's need to be avoided, because that can work as a teratogen exposure can work in a very bad scenario to the babies. So we need to understand what pre-pregnancy workup talks about. It's just the complete information that a patient should preserve with them, as I said, supplementation, what needs to be taken, what needs to be avoided, along the side certain hormonal evaluations also. So karyotype report of the female was normal, Mrs. X was normal. Karyotype of Mr. Y was suggestive of pericentric inversion on chromosome Y, where it is like 46X inversion on Y chromosome from P11Q to Q13. And further, we see that there is an inversion that could be, to our understanding, it could be good enough to go ahead and tell them that, it is something which is a causative of pregnancy losses to you, dropping them to a complete, trauma. We worked out little, and with a little understanding, and we thought of, like, there can be certain information which could have been deleted or duplicated. So we performed a Y chromosome. It was recommended to perform a Y chromosome microdeletion for the patient, and HPLC was recommended for Mr. Y. Further, hormonal investigations plus EPLA, TORCH, lupus anticoagulant, CBC, along the side HPLC was recommended for Mrs. X also. So it was then evaluated. We talked about, like, if everything falls fine, you may plan your pregnancy, because eventually some of the patients do not love to go ahead with an IVF directly. So they thought of giving one more try to the pregnancy with a 50% chances of having a normal conception. So the karyotype and chromosomal microarray was recommended to the fetus if it is reaching to the 13 weeks of gestation age, or otherwise, if the patient wants to go ahead with an IVF, then a PGT sRNA can be recommended to the patient to rule out the chromosomal abnormalities. So, before taking a pause, there is a certain information I would like to furnish to the recent researchers. CCMB, I think in 2024 or 2023, there is a publication. They identified 8 novel defective genes in male which can lead to infertility. These are this CTN1, cat spread, and ZNF318. So the researchers have characterized a mutation in one of the 8 genes, centrin1, to understand how the mutation affects sperm production. They demonstrated an impact of this mutation in cellular models and found out that arrested cell division causing insufficient sperm productions. So these groups have been researching to understand the genetic causes of infertility for over the 2 decades, and they have shown that 38% of the males with infertility have specific region missing or abnormalities on their Y chromosomes, or the mutation in their mitochondrial or autosomal genes. So to add to, there is a recent publication also from PGIMER Chandigarh. I would be able to furnish it. I'll be sharing it with Dr. Prashant so he can circulate to you all. That talks about, like, involvement of RNAs in infertility. So that would be something interesting to understand, that it's not just that what we have known so far, it's beyond what we have to know till now. So with this, I come to the take-home messages, that one-stop solution for all clinical scenarios is not available. We have to understand that genetic counseling is an integral part to the comprehensive cares in every domain. Family history and genetic testing are the key tools. We should utilize these tools very beautifully. And counseling must be culturally sensitive and non-directive, as I was saying that. Multidisciplinary and collaborative approaches improves the outcome. Definitely, yes. If I am somebody who knows certain things, may not be somebody who knows everything. So it's always important to reach out to somebody if you are stuck somewhere, discuss and opine, and pour out what is there in your mind, and understand and grab the information from somebody else who has already dealt with such cases before. And early diagnosis and screening can save a lot of time for the families, and we can obviously answer to a lot of their questions in meantime. psychological counseling forms a big part of the patient care. With this, I would like to thank you for your patient listening, and I'm open for the cases now or any kind of like queries.
Thank you so much, Ms. Dipti, for this incredible, insightful, and engaging session. Your expertise and the clarity with which you explain these complex aspects of genetic counseling, have truly left us enlightened. We really deeply appreciate the time and effort you took to share your valuable knowledge with us today. At this point, we would like to open the floor for any questions for the audience. If they have any queries or thoughts, please feel free to come forward.
Yeah, Jenny and Deepti, may I ask a question? If I'm excused by Bhupen Singh, who has asked the question. I'm sorry,
Yeah,
I
please,
just
please.
have another meeting. Probably
Yeah.
it's not a question; it's just a comment. The wonderful presentation. But if you see the state of infertility, or the states with largest infertility, I think Goa, Kerala comes on the top. In fact, many southern states, including Telangana. Okay,
Mm.
and there's a large amount of maybe environmental factors largely associated with an epigenetic spectrum, and perhaps it might sound very stupid, but these are the states with largest non-vegetarian diet, if you can really look into those kind of things. And
Mm.
you'll be surprised to know that all these particular states have an average marital age at the age of 25, which is quite normal, and the first state of conception is not less than 2 years after marriage. So there is
Right.
something going on. So I think there is more to do with that mobile radiation keeping in the pockets, which sounds pretty weird, but that is what I personally feel. Do you have any quick comment on this? Yeah, thank you.
So so that's something like like something which we cannot say that definitely yes, these are the factors which definitely plays a role in the background. It's not just the genes and the chromosomes. Obviously the eating habits and consumption, food intake, temperature, everything matters a lot, right? So definitely, as Dr. Prashant, you said it very right. Definitely it is something which can on which there is a research. Still there are certain centers which are trying to understand the balances between these two. So definitely in future we are expecting some kind of like literature associated to the consumption of veg or non-veg foods as well.
Right, thank you. Yeah, over to
Yeah.
Bhupen. Jenny, Bhupen Singh has asked a question. If you want to,
Right.
yeah, please. Thank you.
So, is there any possibility of genetic alteration in children conceived through IVF? If so, what are the underlying causes? So, as I said, like, obviously, what we are doing while doing an IVF is like before we never talk about like, doing a PGT and doing a prior investigation to the fetuses, sorry, to the cells, embryos. So, yes, if we talk about like, there are certain things which